We will move on to Dr. Shatalov from the Russian Federation, and we are looking very much forward to see his experience and how he's looking at this world himself as an experimented specialist in this field. Thank you, Dr. Shatalov, for your attendance, and thank you for your presentation.
So first of all, let me thank you for the chance for present very complicated topics and advancements in tailored cancer treatments, the Russian perspective and applications. My name is Petr Shatalov. I am head of molecular genetics service of our center. Science 2080, a national program of fighting cancer, has been developing in Russia under the control of the president. The main goal of this program is providing a new model of oncology service in Russia, based on modern, effective, and available treatment. The benchmarks of the program you can see on the slide. Here the main points have been developed within the program according to its main goals. So, modern, effective, available treatment, digitalizations of medicine, system and health checkups, nuclear medicine, this is a focus of our center, integration of advanced technologies, and other. This slide, you can see one of the main changes of oncological service in last time in Russian Federation. We can see the three-level system implementations, which provides a simple and fast road to cancer patients. And the first one, the cancer offices for settlements with the population less than 50,000 people, or census without outpatient medical care. They conduct initial examinations and can refer the patients to a regional cancer center. Also, we make the same amount of reference centers for expert level analysis or other investigations for those patients in huge megapolises in the Russian Federation. One of these megapolis is our center. Modern oncology in Russian Federation based on therapy optimization, personalization of therapy, tooling improvement, and prognosis or relapse with instruments that you can see on the slide. In modern oncology, the trend aimed at individual selection of therapy is in accordance with molecular characteristics of patient's tumor. In this case, it's a huge expansion of NGS-based analysis, like panel genes, transcriptomes, whole exomes analysis, and it's for finding optimal treatment for initial tumor of the individual patient. An example of the great variety of target therapy treatment is presented on the slides. You can see the number of genetics markers and associated target drugs. An example of non-small cell lung cancer patient. At all, we can see that big amount of markers we want and must to identify for make for these patients optimal cure, and it's in this case we can see that NGS-based big gene panels and other big methods very neat for patients for optimal therapy up to now. We also can see that evolution of therapy through detailed understanding of tumor characteristics, from blockbuster drug to targeted therapy, genetic based, and to personalized approach like mRNA vaccines and other or patient specified drugs that we make based on genetics analysis of initial patient. On this slide, the scheme of molecular genetics department of our center. We make automatization-based DNA preparation, extraction, sample preparation on Tecan robotization stations, and analyzing from target tests like real-time PCR, target sequencing, droplet digital PCR, up to NGS analysis based on target panels, whole exomes, whole genomes, transcriptomes, and other. And big amount of bioinformatics department in our center too. Currently, one of the progressive drug approaches in the treatment of oncological disease is target therapy based on detection of mutations to target drug. We also produce in our center liquid biopsy for cfDNA detection and detection mutations in KRAS genes, NRAS genes, BRAF genes, EGFR, and PIK3CA for non-invasive diagnostics and monitoring of effectivity of therapy on this patient too. Main features from high throughput sequencing of NGS in oncology include dividing the whole process into stages. You can see that slide. So it's need to pathologist, wet molecular genetics, bioinformatics, and clinical genetics in one case in team for produce optimal service for our patients. We have MGI sequencer G400, and we now processing up to 4,500 samples per month, and about 100 of them are whole exome sequencing. We also have same experience in using same different amount of reagent kits from stock MGI kits. Then we also use first designing for Illumina Roche kits and Agilent kits, and now also use same China kits like Nanodyne Bio and Bazyme kits. And we also research our produced chemistry for hybridization, block oligos, and other kits for optimal of this process. We also now articles submitted for publication that responds our experience in this adaptation. Molecular genetics based on NGS now is in our center is explained on small HRR and HRD score panels, also big up to 600 genes panel for solid tumors and a big amount of solid specified somatic mutations. We also produce whole exome sequencing, whole genome sequencing, transcriptome, microbiome, and HLA typing sequencing in our center. On the slide, you can see our experience for NGS testing in our German variants that we find on exomes and panels, and our experience in this. You can see that we use same amount of different panels, and big amount of it was patients with breast cancer, pancreatic cancer, and other types of cancer too. So in this investigation, we in our center find this amount of mutations on germline variants. A big amount was BRCA, ATM, PALP, CHECK, and other genes according to ASCA up-to-date guidelines for searching. We also I want to explain you our statistics in explaining somatic variants. Again, you can see distributions of tumor locations in patients as well of names as reagent kits that we used for NGS testing in our center. Since 2022, we produce about 800 NGS analysis at our center to search somatic mutations on other chemistry solutions. We also published article about it up to date, and the hungry diversity of oncogenic somatic variants identified by NGS sequencing in our center. And the first three groups variants belong to the PIK3CA, TP53, and KRAS genes, and also genes also you can see on the slide. It's important to note that all listed diagnostic approaches and technologies require a complex, collaborative, ecosystemic approach to data processing, storage, and systematization. One of possible solutions in modern oncological practice is processing big data arrays of genomics, transcriptomics, metabolomics, proteomics, and other omics-based technologies, which combines with data lake concept, data storage, and pipelines for the data processing. This approach makes possible to obtain practical results for patients, such as pharmacogenomics analysis, cardiogenetics, expression patterns, genomic profiling complex, mutation profiling, and the creation of individual test systems for monitoring the effectiveness of therapy by liquid biopsy up to date. The approach has been applied in our center since 2021. Due to the fact of demand, molecular genetics diagnostics indication provides a growing significantly every year. We have now begun to implementations of technology of genomic profiling of tumors that named Ariadna, artificial approach to DNA analysis. We provide a comprehensive NGS analysis for tumors for a pair of tumor exomes and transcriptome analysis. Up to use of this test, we made the personal reports that contains information of genomic changes of humor of particular patients, including TMB, MSA, transcriptome, and other information that we want to see from NGS analysis for patient tumor to practical use before chemical chemistry. The core use of comprehensive genomic profiling, you can see on slide, it's identification of predictive biomarkers, analyzing of tumor mutation burden, the analysis of mutation signatures, microsatellite instability, identification of prognostic markers, pharmacogenomic features of the tumor identification, identification of hereditary cancer, if patient have hereditary problems with this, and comprehensive somatic variant analysis, the determination of the full range of somatic variants to establish complete tumor genomic profile. After use of this technology, the patients has undergone multiple lines of drug therapy without achieving a positive effect, can have a bit of help why use this technology. For the options for standard treatment methods have been exhausted. A rare tumor type or atypical cause of disease has been identified. And other things that are also a big problem for clinicists and needs for a big NGS test for them for correct cure. In our center, the big focus also is nuclear medicine. Of course, it's also the most important areas activity of science 220. Our center has a modern radiation therapy complex, which is the result of close cooperation with our center, with Rosatom State Corporation, big corporation in Russian Federation, and Kurchatov Nuclear Institute. So it's have big PET, linear accelerators, radioactive synthesis models, medical cyclotron, and other things that we use for these things in our center. Also, one of the most promising areas for development of nuclear medicine in Russia is radionuclide diagnostics and therapies that we also use in our center. In particular, the opportunities for brachytherapy open with the development of domestic radioisotope iodine 125 that was developed in our center together with Kurchatov Institute and received a national award in 2017. Here you can also see the list of main use of brachytherapy in our center used by this technology solutions. We use it for prostate cancer treatment, cervical cancer, and uterine cancer treatment, and other treatment. This technology can use and good results we produce for our patients. Thank you very much, colleagues.
Thank you, Dr. Shatalov, for this excellent presentation. I was wondering in the meantime, as I was listening to your presentation, whether, most of the data we know, or at least we read here, are based on the Western European and the transatlantic or Northern American population regarding mutations and so forth. Even though this is a mixed population, of course, I understand. But do you see any specificity in the region regarding the genetics of tumors, certain mutations being enriched, or other features that we might have to investigate maybe further?
Thank you very much for your question. Yes, of course, we make big amount of specified genetic testings, and also have genetic based on Caucasus, differ from Europe population, and in our testing we have a big point for first time see what ethnosis is the patient at before produce PCR testing, because, for example, because PCR testing for Caucasus is no reason, because most frequent mutations for the population are different from other. We use this case not only for breast cancer patients, also we make some science-specific search for population-specified mutations for big amount of cancers. We will produce papers in same time so you can read it.
That's very exciting. I think we will have in the afternoon Professor Csaba Bödör, who has been investigating the Hungarian genome specifically for our country, but he might touch upon that topic as well. If I get back to you in a clinical scenario, can I have a technical question to you? So if you investigate circulating DNA in your laboratory, what kind of tubes do you use? Do you use Streck tubes, or do you have your own development, or do you have something better maybe? And if you investigate these, do you have any kind of minimal residual disease follow-up or testing tailoring therapy to the patients?
Thank you very much for your question. Now we know analyze minimal residual disease, but we plan to implant it to our practice in next year. Now we use droplet PCR based test. It's PCR, so it's same amount of mutation in different types of cancer. And next year also we plan to implement in our practice NGS based liquid biopsy for middle amount of genes in gene panels, and bioinformatics solution for it also.
I see you are also working with multi-omics, kind of. You have different levels of investigations going on. And I have to admit, I'm also a pathologist, and I kind of miss the morphology, which might be important. What's your perspective on that? Is there some readout in the data of the morphology of tumors on an H&E section, or do you use that upfront? Of course, I guess when you enroll the samples for further testing, but do you see a future for that optimistically or more optimistically than Professor Székely does?
I see very optimistically for collaboration with morphological specialists with modern methods of molecular genetics. So in our center also, we first time produce all samples we want to NGS before typical morphological and immunohistochemistry analysis also. So it's symbiosis. It's not kind one differ to one. And up to modern methods of immunohistochemistry and morphological methods, it's very good to produce it up to future.
Thank you so much. So we look forward to more exciting developments, and we hope you can attend in the future in person when we have a personal conference with attendance, and we can discuss this further. I encourage the listeners and participants on any channel to reach out to me if they have any questions, raise hands, comment, chat, and post. I will be happy to read up or even give the word to you. So now we will have a 5-minute break after this session, and we will conclude 11:35 our time, but it's probably already 7:30 in Korea. So stay tuned for Dr. Lee in a few minutes. Thank you so much.
Thank you very much.
Thank you, Peter. Thank you.